morning, everyone, and welcome to Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. And before I introduce our speaker, I have some housekeeping items. So first, we're broadcasting live via live stream and YouTube. And when you ask questions at the end, please use the microphone and to ask questions. This grand round is also recorded and will be available afterwards for your viewing. And for our viewers, if you'd like to submit a question, please text DeBakey, D-E-B-A-K-E-Y, to 37607. Text DeBakey to 37607. And you can also submit your questions via the live stream feed. We also just announced a few conferences that we have upcoming in the coming few weeks. We have the CV Fellows Boot Camp in August 18 to 20. We have the IS-EVS Symposium in September 21 to 23. We also have the CVD Prevention Program on October 8. And finally, our multimodality imaging, cardiovascular imaging for the clinician conference in October 20 to 22. All right, so today we're really honored to have Dr. Rob Beanlands from Ottawa presenting our grand rounds. Rob doesn't need an introduction in the cardiovascular imaging circles, but for those who don't know him, Rob is a past president of the American Society of Nuclear Cardiology. He's the Deputy Director General at the University of Ottawa Heart Institute. He's a former chair of the division between 2012 and 2022. And he's also founding director of the National Cardiac PET Center in Canada. He's professor of cardiology and professor of medicine, as well as professor of radiology. And he's also a career investigator supported by the Heart and Stroke Foundation. Dr. Beanlands started in cardiac PET many years ago, and he taught all of us about cardiac PET, especially in viability, conducted multiple trials in viability, perfusion, inflammation, cardiac allograft vasculopathy, and he's been a great teacher, mentor, and friend, and I learned personally a lot from interacting with him throughout the years. He's also an associate editor of the Canadian Journal of Cardiology and the Journal of Nuclear Cardiology. He's won multiple awards, including the Queen Elizabeth II Diamond Jubilee Medal for contribution to Canada back in 2012. He's also won multiple prestigious awards at different imaging societies, including the Blumgard Research Achievement Award from the Society of Nuclear Medicine. And if you're on social media, Asnik announced yesterday that he is the Mario Virani Lecture awardee for 2023 in September in Toronto. So congratulations on this award, Rob, and we're really excited to have you here to tell us about a journey with cardiac PET, probably a 30-year journey from biological insight to clinical applications. Rob, great to have you.
Thank you, Mouaz, for that very, very kind introduction. I want to thank Mouaz and Dr. Zogby for the invitation to come here, and Jennifer Collins for all her work in organizing my visit. It's certainly an honor and privilege to be here, especially on the coattails announcement from Asnik about the Mario Virani Lecture, to be at the home of Mario Virani. So it's a special moment for me today. So I'm going to share with you the journey with PET. These are my disclosures. I will talk about a couple of tracers that are not approved, and I'll let you know when we do that. But otherwise, it's pretty much things that are approved by FDA and Health Canada. So we're going to cover who, what, when, where, and how of cardiac PET, a little bit about some of the basics for those who aren't in the field. We'll cover metabolism, viability, hibernation, as Mouaz was saying, flow and ischemia, and microvascular dysfunction, a bit about inflammation. We won't have time to cover neurohormonal imaging or valve disease, but I can hopefully talk to people about that during my visit. We'll use clinical utilization guidelines and talk about new paradigms, and then talk about what's next. So I like the proverb that a journey of 1,000 miles begins with a single step. The journey here from Ottawa to Houston is a little under 2,000 miles. So today we're going to have a journey of almost 2,000 miles that begins with a single pet. Pardon my dry humor. But I like to begin with this slide, which is from 1965 and is said to be the first metabolic imaging that was performed. And I show it for a couple of reasons. The first is actually it's a fusion image. It's a fusion of a chest X-ray with a rectilinear scanner of radioiodinated fatty acid. It's also probably the first international imaging collaboration. So these were dogs who had an infarct that were injected with radioiodinated fatty acid. They were injected in Toronto. They were anesthetized, put in the trunk of a car, driven to Buffalo, New York, where there was a rectilinear scanner, and they were scanned there. So it was an international collaboration. Of course, we couldn't do that kind of collaboration today, but we have different ways of collaborating, of course. And the third reason is that this is not my first publication, but this happens to be my father, Donald Beanlands. Basically, I think he was unenamored by nuclear and went into interventional cardiology. And there we are, the three Dr. Beanlandses. All right, so imaging has come a long way. We can now, with PET, do perfusion, of course, gating, there we go. We can quantify biological parameters. We can fuse it now with CT and MR and with AI. I'm not going to be showing pictures with AI, but we can do so much more than we could in 1965. So this is my granddaughter, Noemi, one of my 6 grandchildren, and she's going to help us through this talk, talking about a few things and giving her renditions of different topics. So the first is what? So what is PET? So PET is positron emission tomography, beginning with a radioisotope nucleus that emits a positron, that it collides with an electron. Now, positron is actually antimatter. Now, how cool is that? It's antimatter. I just, anyways, it's amazing. And through Einstein's laws of physics, the two annihilate and emit 2 photons in equal and opposite direction. And it's this actual beautiful physical principle that allows PET to do what it does. So if we place detectors on opposite sides in a ring, we can precisely localize where the event has occurred between the two because of these coincidence photons. And it's this that allows us to measure and track molecular function processes at a picomolar level, gives us superior functional accuracy that allows biological quantification, and that leads to the diagnostic and prognostic value of PET. Of course, it does have disadvantages. Access and cost are an issue, but there are now low-cost PET options. Resolution is an issue. It doesn't have the resolution of echo, CT, or MR, but there are now digital cameras that have improved resolution, and of course you can combine it with MR or CT to overcome this disadvantage. It used to be that there was real dependence of being having a cyclotron at your facility, but now with generators, with rubidium, and with F-18 tracers, this is no longer necessary. Of course, there is radiation, but the radiation for perfusion imaging is actually quite low, less than 2 millisieverts, which is equivalent to approximately 2 to 3 mammograms. This is what's happened with the utilization of PET at the Heart Institute in Ottawa. And you can see that nuclear imaging with SPECT has been on the decline, and PET and CT have been on the rise. So the physicians are speaking with their referrals. They see the value, and we're getting more and more. All right, so we're starting in Ottawa, which is straddled by 2 suburbs, both of which are my grandchildren. 3 of my granddaughters and my grandson are at opposite ends of the city. And this is Noe's interpretation of hibernation. So we'll move now to talking about viability and hibernation. And what we're talking about is dysfunctional myocardium. And what we're trying to do is, in the dysfunctional myocardium, distinguish viable, recoverable myocardium from non-viable scar. viable myocardium can be remodeled and normal. It can be stunned or it can be hibernating. And it's the hibernating tissue that's most relevant for us in terms of improvement of function and outcomes. So I like this slide that I first saw from Marcello De Carli. I've adapted it a little bit. If we begin with talk about patient 1, a 55-year-old woman with class 2 to 3 angina, EF of 30%, good targets, no comorbidities, the decision to revascularize is pretty straightforward. As opposed to this 80-year-old man with heart failure, prior bypass, very poor LV function, big ventricle, mediocre targets, poor renal function, COPD, the decision to revascularize is not so easy. So for Julia, she would have been a candidate for the Stitch trial, whereas Harrison, he would not have been. And I put it to you that this is the type of patient where viability imaging is the most useful. So what are we doing with this? We're using FDG, which is a glucose analog. It goes into the cell in the same way that glucose does. It's converted by the hexokinase reaction to FDG6-phosphate, just like glucose is. But at that point, it's trapped. And because of that, we can actually image the glucose utilization and the metabolic activity of the cell. So here's an example of a patient with a large perfusion defect in the anterior wall and inferior wall, but with maintained FDG activity. And this is so-called perfusion metabolism mismatch and is an indicator of myocardial hibernation. On the other hand, this patient has significant reduced perfusion that's matched with FDG uptake, indicating myocardial scar. This patient would be expected to have improvement in function and potentially outcome, and this patient would not. So FDG has been shown in observational studies to be the most sensitive, whereas dobutamine studies with echo or MR have been shown to be the most specific. And I like this slide, which kind of helps us to explain why this is. So if you look at these tissue samples from hibernating myocardium or normal myocardium and hibernating myocardium, you can see the normal myofibrillar bands in the normal tissue, whereas in the hibernating tissue, there is destruction or myocytolysis of these myofibrillar bands while the membrane is still intact. So the cell is still alive, but you can imagine here why this cell won't respond to dobutamine. On the other hand, this is PAS staining looking at glycogen, and you can see that there's still a lot of glycogen uptake and glucose uptake in these cells. So FDG would be expected to be taken up by these cells that are alive but not functioning very well. So FDG is sensitive, but not as specific, and dobutamine is not as sensitive but is more specific. So we did a trial that we published in 2007, and then a follow-up of that a little bit later, where we compared FDG PET imaging being done in patients to not being done, and used that to try to direct therapy. And what we showed was that there was a trend for outcome benefit when PET was used, but it did not reach statistical significance. So it was a negative trial overall. However, about 25% of the patients did not adhere to the recommendations that the imaging provided. So if we suggested to revascularize, the physician and patient did not undergo revascularization, and if we suggested not to, they sometimes did. When we considered that in a post-hoc analysis, we actually were able to demonstrate that there was outcome benefit, suggesting that you can get significant benefit when you adhere to the imaging recommendations. Of course, you do have to take into account the entire clinical picture. So then along came the Stitch trial. So Stitch, we know, after 10 years, showed an outcome benefit with bypass surgery for patients with ventricular dysfunction. They also looked at viability in about half of the patients. And what's of note is that when viable myocardium was present by the methods that they chose, there was actually an outcome benefit. When viable myocardium was not present, they were not able to show that there was a benefit or not from revascularization. And And what they were also not able to show was the interaction of the two in terms of viability and bypass surgery. But it's possible that they weren't powered to do that. It wasn't what they intended to look at the beginning of the trial. So, what does this tell us? We know that viability is not the only predictor of outcome. We know that viability testing is not needed in every patient, but it doesn't mean that viability imaging is not useful. And then along came the revised trial, again challenging our thinking around viability. So they took patients with 4 segments of viable myocardium and randomized them to PCI versus medical therapy. And they were not able to show outcome benefit. Some of the comments about the trial have been that they didn't necessarily all have 3-vessel disease nor angina. They may have had other forms of cardiomyopathy. They did not assess ischemia per se, and technically they had limited assessment of hibernation. So again, it doesn't indicate that hybrid imaging is not useful. It's just that we may not be getting the target right. So what about stitch, revived, and PAR 2? So some of the differences are that in PAR 2, unlike revived and stitch, the patients were not necessarily known to be good candidates for revascularization. We randomized patients where the revascularization decisions were thought to be uncertain. Most of the patients in PAR 2 had multivessel disease, whereas you can see half of them had 2-vessel disease in revived, and 25% had single-vessel disease in stitch. Very few patients had renal dysfunction and prior CABG in stitch and in revived, whereas a third of the patients had renal dysfunction and almost 20% had previous bypass in PAR 2. So we're talking about somewhat different populations. And in terms of the methodology, stitch did not use PET or MR. Revive did use MR. There was a small amount of PET imaging, but it was mostly MR and other methods, whereas FDG PET was used in PAR 2. So I like this summary slide that I saw from Amit Patel, really asking the questions, are we really defining viability correctly? How much viable myocardium is actually needed? Does viability imaging now, in the modern world of excellent medical therapy, does it actually identify patients with ischemic cardiomyopathy who can respond to medical treatment as well? Do we need longer follow-up? We do need more comprehensive comparative effectiveness trials and randomized trials. So I'll move to a couple of these. First, the ischemia trial, which recently they published a sub-analysis of the patients who had, the group of patients who had reduced heart function and or heart failure. And what they were able to show is that in this high-risk subgroup with heart failure and low EF, an initial invasive approach was actually associated with better events outcomes. So I felt that was kind of interesting in spite of the overall negative result between revascularization and medical therapy. When you looked at the patients who were higher risk, revascularization seemed to be of benefit. And we've conducted recently a randomized trial combined with a large registry to look at both ischemia and viability. This is in over 1,300 patients. We had difficulty with randomization, so we ended up combining it with a registry population, and we compared advanced imaging as the first step with a PET or MR to SPECT imaging. And what we found was that there was a slight benefit with CMR or PET compared to SPECT, but this did not reach statistical significance. That was for the total study population, and also in those who got ischemia imaging, similar. However, when we looked at a predefined secondary outcome, which was cardiac death, we were able to show that, in fact, there was a significant benefit when CMR or PET was used compared to SPECT for ischemia detection. What's interesting here is that these curves start to split at about 2 years, which is around the same time as the curves cross in the STITCH trial. The other thing that we've looked at and are exploring in the ischemia in our image heart failure trial is the fact that in this small cohort, when patients had large amounts of hibernation, they also had high BNP and high troponin, suggesting that these may be complementary to the viability information. The Buffalo group has also looked at the use of HED, which is a neurohormonal imaging agent that images the presynaptic neuron with hydroxyephedrine, and were able to show that it, among other factors, was a predictor of sudden death. So whether or not these can complement viability and ischemia imaging remains to be seen, but I think there's still a lot we have to learn. So if we look at where viability imaging testing is unlikely to add useful information, it would be patients where the dominant symptoms are angina, where they already have demonstrated ischemia, where they have normal or only mild LV dysfunction, where they have left main disease, and when they have no or limited comorbidities. It may be helpful in older patients where heart failure predominates, where they have persistent perfusion defects, that is, no reversibility, where they have moderate or severe LV dysfunction. I think the jury's out on chronic total occlusions, but when they have severe or multiple comorbidities and you're really trying to make the best decision for the patient, these are the patients that might benefit from viability testing. We know that FDG and MR are highly sensitive for viability. We know that they're most useful when decisions are most difficult. And from our image heart failure trial, that ischemia evaluation, the overall type of imaging may not matter when you look at the composite endpoints, but you may have some advantage of advanced imaging associated with reduced cardiac death in the long term. Whether biomarkers, neurohormonal imaging, and AI, which I'm not going to talk about, but whether these can define or better define which patients benefit from image-guided therapy remains to be determined. We still need randomized trials in this area. All right, so we're moving on our travel. We're traveling now I'm coming from Ottawa to Houston. I got to go through Toronto. It's not a bad place for me to stop because my grandsons are just outside the city. So we're going to talk now about flow. So PET flow, or flow in general, we're measuring flow reserve, is the capacity of a given vascular bed to maximize flow. It's the ratio of the stress flow over the resting flow. And when we're measuring it with PET, we're measuring the integrated measurement of the entire vascular tree. So the epicardial vessel, diffuse atherosclerosis, if this is present, and microvascular function or dysfunction. A couple of other concepts that have emerged are the PET flow capacity, which is plotting the relationship of flow reserve and stress flow. This has been championed by Lance Gould and Niles Johnson. And PET coronary vascular resistance, which is the blood pressure, the stress blood pressure over the stress flow, which is an estimate for vascular resistance and may be helpful in some populations. So we'll talk a little bit about these. So here's Noe's wanting to know, why do we want to measure flow? So flow measurements overcome the shortcomings of relative PET and SPECT perfusion imaging. They have high negative predictive value. They're more precise and more sensitive for diagnosis. They can define physiological significance of a stenosis. They give us the entire spectrum of the disease from microvascular to advanced diffuse disease. They provide incremental prognostic value both in coronary disease and non-coronary disease states. They have the potential to direct therapy, and they provide assurance that vasodilator stress has actually been effective. The ones I put in highlights here are actually highlighted in the guidelines, and PET is given a class 1 recommendation for detection of disease and defining ischemia in the recent chest pain guidelines. 2A for the use of PET in microvascular dysfunction, and 2A for the application of flow, with these points highlighted, as I mentioned. So why is this possible? Why is this relevant? So what happens with a tracer is that it has to be extracted by the myocardium, and as flow increases, the tracer extraction rolls off. However, if you're able to measure flow, you can establish a more linear relationship, which allows you to be more sensitive and measure the global flow and the regional flow values, which provide the added value that I've already mentioned. So How? No, he wants to know, how do we do this? So this is a rubidium generator, and the green dot indicates the rubidium, which passes into the right ventricle. We see the right ventricular blood pool, passes through the lung and into the left ventricle. We see the left ventricular blood pool. Then it's gradually taken up by the myocardium and washes out from the blood. So the myocardium is shown, time activity curve is shown in blue, and the blood pool is shown in red. So we then take this data. Now, this type of image here, this is what static imaging with SPECT or PET uses, the late uptake images. And this is, whereas flow, all of the action is in the first several minutes. So what happens here is we take this and we apply a mathematical model that looks at the blood and the tissue. And we look at, with this, we use the mathematical modeling to create what is the true myocardial curve, uptake curve. And we can, from this, we can determine the rate constant for its uptake from the blood into the tissue, the K1, which we know relates to flow and extraction. And from this, we can calculate myocardial blood flow. So here's an example. This is a patient who had a tetraphosmin, which is similar to sestamibi, SPECT imaging, which looks pretty much normal. The relative PET perfusion imaging shows an inferior defect that looks reversible. So the PET is more sensitive, but even relative PET imaging doesn't pick up that, in fact, there's a global reduction in stress flow and flow reserve. The normal here in our lab should be 1.5. Normal here should be, or low risk here should be greater than 2. And so this suggests that there is multivessel disease. We do see the calcification, but that doesn't tell us if it's obstructive. And what you can see is this patient had an osteal right and left main disease and obviously went on to bypass surgery. So how does it compare? So the Pacific trial compared PET, SPECT, and CTA to each other and looked at the functional significance based on invasive angiography. And PET was the most accurate among these tests. They further looked at patients who had CTFFR and were able to show that when you look at the patient as a whole, that PET was the most accurate method for detecting disease. We also know from this elegant study by Venk Murthy that as the flow reserve reduces, the outcome actually worsens. So it is a significant predictor of adverse outcome and has prognostic value. And we've shown, and others have shown, that this provides incremental value to the sum stress score, which is basically the relative perfusion imaging defect size on the stress images. Shown here by Mouaz and colleagues, you can also look at calcium scoring, and you can see that as calcium scoring increases, the prognosis is worse. However, if you add flow data to this, you provide even further incremental information. An elegant study by Viviana Ticchetti has shown that when, if you look at revascularization responses for patients who have low global flow reserve, these are the ones who are most likely to benefit from bypass surgery. The Kansas City group looked at over 12,000 patients and showed that as you reduce flow reserve, if you look at revascularization in red and medical therapy in yellow, you increase the likelihood of benefit from revascularization when flow reserve is globally reduced, similar to the Ticchetti study. So moving now to from the large vessels to the smaller vessels, which occupy 75 to 80% of all the vascular tissue in the myocardium, we can now look at microvascular dysfunction, which gives us a window into other disease states, microvascular disease itself, transplant vasculopathy, hypertrophic cardiomyopathy, aortic stenosis, amyloid, and even potentially heart failure with preserved ejection fraction. So this is a study by Gupta, another great study from the Boston group, looking at the relationship of flow reserve to maximal or stress flow. And what they showed was that in this cohort here, with low flow reserve and low stress flow, these patients had the highest mortality. And these are the patients basically with obstructive disease. However, this group of patients which with low flow reserve but high stress flow also has significant mortality. These patients did not have obstructive disease. Rather, they probably had more microvascular dysfunction. They also had more HFpEF, and it was more prominent in women. So having all of these measurements provides us some important prognostic information for our patients. Again, Viviana Tecchetti has looked at this in the HFpEF population, or looking at HFpEF, and demonstrated that when you have HFpEF parameters on echo and impaired flow reserve, these patients had the highest risk for rehospitalization, which was actually 5-fold greater than other groups. So I want to move now to an example from a transplant patient here. So this is a 61-year-old man who had presented with HFpEF and chest pain. You can see his perfusion scan is almost normal, relatively, but if you look at the stress flow and the flow reserve, these are markedly impaired. Unfortunately, this patient died, but he did have autopsy, and this revealed that there was concentric interval thickening and chronic inflammation typical of cardiac allograft vasculopathy. For cardiac allograft vasculopathy, there's now actually at least four, possibly more studies that have shown the diagnostic accuracy of PET for defining CAV, or cardiac allograft vasculopathy. And there's now at least 5 studies that have looked at the prognosis. So when the flow reserve or stress flow parameters are lower, there is worse outcome. In our hands, our heart failure transplant director, Sharon Chi, has established 3 parameters based on PET imaging, and when at least 2 of these are present, we refer these patients for angiography. When none of them are present, we continue to follow them non-invasively with PET. And this has prompted us to initiate a randomized trial, which we're about to start in Canada, that will compare PET to invasive angiography strategy for following these patients. So some facts about PET flow, if I can summarize. So it's of interest that FFR as a measurement, as an invasive measurement, was actually first validated against PET. That FFR actually complements the information from PET because they can have the potential to define discordant populations. So patients with a high FFR may actually still have microvascular disease, and PET allows us to help dissect that patient population. As I showed from the Pacific trial, that PET yields the most accurate per patient ischemia diagnosis compared to other techniques. It has incremental prognostic value. It can detect diffuse disease, microvascular disease, and CAV. It can predict responses to revascularization. It can detect non-responsiveness to pharmacological stress. We didn't really go over that, but it can. Yet, the full clinical value is not yet realized, and we still need RCTs, some of which are being planned. As one example, this is the reimagined CAD, which is a proposed RCT. It's under review right now at PCORI. It's being led by Marcello De Carli and others. It will compare PET to CT in high-risk subset populations, and also look at patient-centered reporting in a 2-by-2 design. I can't leave the flow world without talking about florperidaz, which is not approved by FDA yet, but recently the second phase 3 trial was completed, and they were able to show that of using PET versus SPECT for overall detection of disease, this is on relative imaging alone, doesn't even consider flow, that the sensitivity and specificity were superior with florperidaz. The advantage of florperidaz is that it's F18, which means it has a longer half-life, which means you can potentially exercise the patient, which I think is an exciting adjunct to what we do now with PET. Also, it may have better extraction properties such that the flow quantification may also be more accurate. All right, so now we're arriving in Houston. Oddly enough, this is a NASA rocket in Montreal. So here's my granddaughter in Montreal with Anyhow, so we're going to talk now about inflammation, and we'll begin with cardiac sarcoid. So the guidelines in the last 10 years have evolved from previous guidelines, and now MR and FTG are well embedded in the guidelines as techniques that can be useful in the diagnosis of these diseases. And I know you guys are quite active in evaluating sarcoid with FDG PET and MR. The accuracy has recently been, there's been previous meta-analyses, but the most recent one is more up-to-date, and it actually shows an accuracy overall of close to 85% for FDG PET for diagnosing cardiac sarcoid. We know that the prognosis information is valuable for both reduced perfusion or FDG hotspots. Whether you have one or both, these patients have worse prognosis. So it provides added value in that respect. So who should get FDG PET imaging? So the Heart Rhythm Society guidelines recommend that in the following scenarios, that when you're screening for young patients under the age of 60, and I think they're extending that to 70, 60 is pretty young, I think. In any event, that FDG PET should be a first-line test. When you're screening for cardiac involvement, if someone has an abnormal echo or abnormal Holter or something like that, or symptoms, then MRI would be the first test to use. When you're following responses to steroids and other immunosuppressive therapy, FDG PET, and they also recommend FDG when there's active disease in patients with manifest cardiac sarcoid or there's increased ventricular arrhythmia burden. So here's an example. This is a 44-year-old man. Actually, he was coming back from Afghanistan to Canada, and he had developed, had a syncopal episode and was found to have third-degree heart block. And so he underwent FDG, and you can see on the whole body imaging, there's some lymph node activity. You see a sort of patchy cardiac uptake. On the fused image, you can see uptake in the septum, at the apex, and the right ventricle, which in itself is a poor prognostic sign, and even atrial uptake. The perfusion, though, is pretty normal. And you can see again on the reconstructed images the patchy FDG uptake. So pretty typical of sarcoid. The patient, however, declined steroid therapy, and this is what happened. You can see now that the FDG uptake is more extensive throughout the myocardium, and now there's actually developed perfusion defects. Fortunately, he had an ICD inserted because about 2 weeks after this, he collapsed and had sudden death, but was resuscitated. And after that point, he went on steroids, and has improved since then. So again, looking at randomized trials is our best way of trying to determine evidence. We're conducting the CHASMS trials led by my colleague David Burney, where we're using PET and SPECT perfusion and FDG uptake as endpoints for the trial to look at the effect of standard steroid therapy versus methotrexate and other immunosuppressive therapies for these patients. All right. Continuing on in Houston, we're going to move to some other infection and inflammation imaging, beginning with devices. So this is a patient with an ICD who had pain and had a negative ultrasound and underwent FDG PET. And what you see here is uptake around the pocket. Now, what's important for those who are in the imaging field is that that we look at both the attenuation corrected and the non-attenuation corrected images to remove the potential for adjacent metallic artifacts that can affect attenuation. And indeed, this patient has uptake on both images. So typical of a patient who would be considered positive. And if we look at the meta-analyses of these trials, when it's in the pocket and the pocket's in question, the accuracy is very high. So FDG is extremely useful in this population. When it's in the wire, less sensitive, still pretty specific, but still reasonable and a reasonable adjunct to echo and transesophageal echo in these patients. Moving to valve, prosthetics valve in particular, This is a very nice summary paper by Pizzi et al., which really kind of highlights the differentiation with prosthetic valves of different types of uptake. And what you see here is the typical pannus uptake, which is pretty uniform throughout the valve ring. It's not very intense, whereas this patient with endocarditis has a very hot area just outside the valve ring, and also very, very intense. So these help us to differentiate this type of patient with prosthetic valve endocarditis. So much so that it's now accepted in the European guidelines as a valuable tool and adjunct when you're trying to make the diagnosis when there's uncertainty about the diagnosis of endocarditis. This meta-analysis by Wang has shown us that the overall accuracy is again about 85%, so pretty good for prosthetic valve endocarditis. Not so good for native valve endocarditis. So the pooled specificity is very high, but the sensitivity pooled is low. However, as shown by Primus et al., if you use the modified Duke criteria and then add PET imaging to it, you can enhance the diagnostic potential for both native valve endocarditis and prosthetic valve endocarditis. So when should we do this? So based on the data from Primus and from others, the ACC now recommends that whether it's native or prosthetic valve, that if there is suspicion and it's only considered possible with modified Duke criteria, that FDG PET has a two-way indication. All right, so here's Noe and her interpretation of a Texan. I'm going to move now to atherosclerosis. And we all know that the vulnerable plaque is the culprit for our acute cardiac and vascular events and plaque rupture. Our current paradigm is generally to evaluate stenoses and ischemia, and I've talked a lot about that today. But a potential future paradigm is to target inflammation and lesions that are likely to rupture and trying to detect these. And so there are a lot of targets that PET that have been used with PET. FDG, of course, being the mainstay, but sodium fluoride also, and dotatate, which I don't actually know if is approved in the US. It's not in Canada. But I'm going to talk mostly about FDG. So this is an example of a patient with a lot of aortic FDG uptake who ended up having a subsequent event. Another patient with a cardiac history who does not have much in the way of aortic uptake, who did not have an event. And this is kind of an example of the two diametrically opposite types of patients that have been shown now in as many as 4 studies that if you have high vascular FDG uptake, you're more likely to have vascular events. So again, supporting the inflammation hypothesis. What's interesting here is that if we look at drugs that have been shown to have outcome benefit with patients with vascular disease, statins, pioglitazone, canakinumab, compared to those that have not, and then we look at studies that have looked at FDG response in these patients, you can see that this is the parallelism is there. So FDG may actually be a valuable surrogate to looking at these patients. And this has prompted us to conduct, we're doing this now, a randomized trial we're calling Cadence, which is comparing colchicine to placebo in patients with recent vascular events, stroke or MI or ACS, who have diabetes or prediabetes. So a high-risk subset to see if we can tease out if there is a potential to use PET to identify these patients who are potentially at higher risk. All right, so what's next? That's Noe with her little sister. So I'm not going to go through these. These are mostly not approved tracers, but because of the problems with FDG, it's taken up by the myocardium and inflammation. We need to have intense preparation of the patient with fasting, with a diet for at least 24 hours or more, that preps the patient, and they don't always comply with that plan. This problem, plus the fact that it's taken up by the myocardium with ischemia and hibernation, make us want to explore other tracers. And there are a lot of them out there that are being explored. A few to particularly highlight would be sodium fluoride, which has been nicely shown by Newby and colleagues to be taken up in the coronary vasculature, so potentially allowing us to look at the coronaries, not just the aorta and the carotids. And of course, it doesn't get taken up by the myocardium. This study, however, was done after events. What we want is something that can define things before events. Likewise, dotatate has been shown to be superior to FDG in this regard, and again, potentially identifying coronary inflammation. Again, though, after events, not predicting before events, which is where we want to be going. All right, so to summarize, so FDG PET is highly sensitive for hibernating myocardium. It's best used in high-risk patients with reduced ejection fraction where decisions are most difficult. PET flow provide accurate prognostic information that defines a spectrum of disease, of obstructive to microvascular dysfunction. For sarcoid, FDG PET is considered first line in young patients with high-grade AV block and is the test recommended for follow-up. It provides helpful diagnosis and prognosis for prosthetic valve endocarditis and device infection. It's less sensitive, but still valuable in native valve endocarditis. It reflects inflammation and atherosclerosis, which has prognostic value and may be a target for other novel anti-inflammatory therapies. So what's next? Well, we need to, I think, overall redefine the role of imaging, not just PET, but all imaging in the care continuum. Which patients are most likely to benefit from image-guided therapy? In hibernation, what's the right question? What's the right patient? What's the role of biomarkers and other adjuncts? For flow, understanding the microvasculature, monitoring and actually developing new therapies for these patients. And in inflammation, can we actually use it to direct therapies? We want to focus on value-based imaging and high-quality evidence. We need more randomized trials to evaluate impact on outcomes, quality of life, and costs. I've given some examples of projects that are planned or ongoing: Reimagine, Mariner, Chasm, and Cadence, but we need more. I didn't cover AI, but I think that there's a lot of exciting work being done, and I know some work being done here to answer the question whether AI can help us in this, to help with decision-making and improve outcomes. So I'll thank my imaging colleagues in Ottawa. We have a great team that helps us every day. And of course, my family back in Ottawa. Thank you.
Thanks, Rob, for a great tour de force, really, on all the applications of cardiac PET. And I'm glad that we have all these applications here, and this has taken up significantly over the past 3 years and done probably around 9,000 to 10,000 cases as of now in the past 3 years, covering all these important applications here. So at this time, we're going to open it up for questions.
Rob, thank you. Thank you for coming. Thank you for your leadership in the field. And your contributions and your team has been really amazing. A couple of questions for you. Some of them are intriguing a bit. One is the area of viability. Mm-hmm. I know you and I are a bit disappointed as to the advantage, if you will. I think we go a long ways where retrospective studies were much more impressive in management of patients. So conceivably, in a select group, they could be much more impressive than in the general population. And I think you've addressed some of that. And maybe, question to you is, over time, since 15, 20 years ago, medical therapy for ischemic heart disease and heart failure has really improved. So it sounds like, and I agree with you, that the applications are in the high-risk individual where you're wondering really what to do. Do you agree with that overall?
Yes, I completely agree. And I think some of the problems have been, and even in our own trials, that we're trying to apply it to a broad population when really we should be focused. And I think we did a disservice to ourselves, in the 90s, early 2000s, when really viability imaging was taking off. People were using it in almost every patient when it wasn't really adding value. And I think as well, the concept of viability has been misunderstood as well. So, technically, tissue is viable if it's functioning. It has to be viable. And you can have viable myocardium that's actually not hibernating, that's dysfunctional because it's remodeled and so on. And these may have different responses to different therapies. So, so I completely agree that we probably have not targeted the right patient population, and the examples that I gave for Stitch are kind of case in point, that Stitch was a very directed population, and everybody, half of the patients anyways, they weren't discriminatory, and they didn't use it for decision making. They just used it in the patients that were going to get surgery. So they didn't really define that patient population, so I think we're still looking for that. I think your point, the other point was that medical therapy has advanced, and of course Stitch was in an area when medical therapy had not been advanced. We now have Entresto, we now have really multiple guideline-directed medical therapy that really, really do improve patients. We all see it, how effective it is. So whether we maybe need to start to shift our thinking about using viability to help us direct therapy in general, and using other parts of the information, how much is hibernating, how much is scar, to help us decide are the patients going to be better suited for medical therapy, revascularization, transplant, and so on.
Other question for you, very interesting data on myocardial blood flow and reserve. That right lower quadrant where myocardial blood flow was preserved, but the reserve was reduced. Is that because resting blood flow was high for whatever reason in those situations, either hypertrophic state or something like this, and still you said it had negative effect down the line? Is that the reason?
Yes, so you're exactly right. So if the stress flow is high and the flow reserve is low, the rest flow has to be high. So those patients are an interesting group. What we can say is they don't have obstructive disease, but something is going on in the myocardium. And you're right, it could be hypertrophy. A lot of these patients have hypertension. A lot of them have HFpEF and so on. And so again, how do we use that information to, and this is the same with any kind of imaging information, how do we use the imaging information to help select a therapy that's going to improve outcomes? And I don't know that we have that yet for that patient population. So that's why it's exciting in the sense that there's a lot of unanswered questions that we need to go after and try to find out what the solutions are for patients.
And last question, flurpiridaz, not
Yes.
yet approved, but its advantage certainly is exercise. If it were to be approved, what is the role of SPECT?
So the role of SPECT, so if I can be blunt for flurpiridaz, I would say the key for flurpiridaz is the price point. So it has value, but at what cost? So the company needs to come in at the right price point to make it affordable. And that will make it the preferred choice. If it's put at a price point that's not affordable, then people will still use SPECT. And if you look at outside North America and Europe, SPECT is used around the world. So it is pretty ubiquitous. So it's going to be a big transition. But if they get the right price point, I think that people will even countries where SPECT is a stronghold will start to use PET imaging. And certainly my own view is that PET should be in any advanced center or any center that's providing tertiary level care, you should have cardiac MRI, you should have cardiac PET, you should have a strong echo lab, you should have cardiac CT, you should have all those things available to make the best choice of imaging for your patient.
A spectacular journey.
Thank you.
With Noe, is that her name?
No, me, yes.
And, you know, sometimes getting to Houston, I'm actually originally from Louisiana. You have to go through Louisiana, and you might have to have hip boots on. You might get stuck, you might step in a hole. And I'm getting to the point of the use of PET in high-risk patients, the Harrison Fords, the Clint Eastwoods, the Robert De
Yes.
Niro's. Now, it seems clear that if you have no functioning, if you have a scar, you can't trap. You can't phosphorylate glucose. So that's easy. What percentage has that test that shows no trapping that proves that it's scar? Is it 20%, 30% in that population? So if you have 100 of these people that are at high risk and you're trying to decide do you need to revascularize or not, you know, at some point, what percentage actually you can eliminate because it's all scar?
Yeah, that's a good question. We're still looking at our data in the image heart failure trial, and I want to say, but I say this cautiously because I don't have I have to go back and look at the numbers, but with the very large scar would be 25, 30%.
I mean, I'm guessing. I'm not a cardiologist, but I'm just guessing from living in ICUs. I'm a lung transplant, heart transplant specialist, part of ISHLT, so that's my guess. And it makes us scratch our head, and I'm going to go back to Noe, my grandchildren, and Einstein. What did he say? Imagination is
right.
More important than knowledge. Knowledge is limited imagination. So the child helps us, because what you presented to me, I got more questions now.
Yes.
So now I do this test in Clint Eastwood, and it's not negative. So now I'm scratching my head again. What do we do next? You see, because it's not specific, but it's not a negative test. So still we might have a way to preserve performance.
Yeah, and I think it's about taking the whole patient's picture, their clinical scenario, but also what's their health trajectory, what's their health journey, like what do they want? Because if they're 80, there's nothing you're going to do that's going to make them live longer. So are you going to be able to improve their heart failure, improve their symptoms, improve their quality of life? Like that's the questions they want to know. And so you have to take all those things into account and then talk to the patient about it and go from there.
Because it makes me wonder, and as my grandson says, what does this all mean? Should we have really done the test? I mean,
absolutely.
Because now should we really do this test if we're thinking personalizing precision care, you know, right? I mean, that's my thoughts as we go through this journey.
So you're absolutely right. So care should be personalized, and precision is what we're striving for. And what I try to teach our trainees is that when you're ordering a test, you have to think about what's the outcome of the test before you order it. So it's either going to be positive or negative. Hopefully it's not equivocal. We try to eliminate all that possibility. But so you're going to have one of those two outcomes. So what are you going to do with the information once you get it? And you have to tell the patient that too. Like explain, if the test is negative, we're good, right? If the test is positive, it's going to support what we think, and this is the path we're going to take.
And I think, just to go back, I mean, for the viability, obviously, when we do this, you have to look at the overall patient. And it's not just viability, as Rob showed, that will determine the outcome of the patient or the management strategy. I think you look at the LV, concomitant disease, targets, the coronary status, and everything else that will help you in terms of determining what would be the outcome.
And we're heading towards artificial intelligence because each question, each test we do is on a different path. And we're talking of extremes. The easy extreme where you had Julia, young, easy, don't need it, older population. But the bulk of the decision making is going to be in that crowd in between. Case in point, somebody's had their valve replaced 20 years ago and they're 60 years old. Now we're wondering, should the surgeon operate on a valve? Because sometimes they go in there, they have nothing to sew into when they have to remove the valve.
Yeah. So I'm just going to take it on a different direction. So for transplant vasculopathy, we're doing now many of these cases. Tell us about your experience there. Are you doing them early, late? Because there is some data that like the numbers would change year by year because of the chronic changes in these coronaries after transplant.
Yeah, so a couple of points about that. The first is the transplanted hearts are usually young hearts. And so the flow cutoffs that have been established, this value of 2 is based on prognosis, right? It's not based on normalcy. And so we actually now don't say greater than 2 flow reserve is normal. We say it's low risk, okay? That's the first point. And from Sharon Chi's work, the cutoff in the transplant patients was actually higher in terms of defining CAV and so on. There's a recent, Sharon has published in the heart failure, I think it was JACC heart failure or CIRC heart failure, I don't remember which, but looking at the early detection. And I'm talking early, like 3 months to 1 year. We also, it's under review at the moment, but we also did this with PET. And it's not as good because there's so much else going on. It's more patients, and a lot of the studies that are done are actually longer term. So that's why we want to do Meritor. It's going to be basically patients who are 2 years out and beyond, and look at it compared to angiography.
That's my point. I mean, most of the time we should use it like a little bit longer after the acute phase because of all the acute changes. And finally, I just want to ask you, like, we know in the U.S., like, the best estimate for the number of PET sites for a country as big as the U.S. is about 400. Many of them are just doing flow, like perfusion, not even flow or any of the advanced applications. So tell us about your experience. I know that you started, like, you're directing the national PET program for Canada. And what are your efforts to make this modality available? You have more than just 1 or 2 tertiary care centers that take care of your patients. And how do you ensure that all your patients across the country have access to these important applications when they need it?
Yeah, so it's been a struggle because of cost and so on. I'm excited to say that Toronto, our biggest city, finally has PET, cardiac PET imaging. They've been doing FDG, but they're going to have flow and perfusion. Our site, Montreal Heart, basically, they kind of did what you suggested. They basically said, we're not doing SPECT anymore, and they've just got 2 PET cameras. There is places that are adopting it at different rates. I think what we've started to do is basically convince, because we're publicly funded, we have had to convince the government to do that, and different jurisdictions. It's provincial, just like a lot of stuff you guys have that are state-run. It's harder to make that kind of a national thing. So it's been harder to do that because each province has a different approach. But the main provinces, the big places, are all getting PET, and the big centers are getting PET. And the ones that have transplant programs, pretty much all of them now have PET for flow, or will soon be getting it.
All right. So if there are no more questions, I just want to thank Rob Beanlands for being with us from the home of Mario Virani for the Mario Virani lecturer this year. Great to have you.
Thank you very much.